Welcome
Perfect.
back to Super Doc Stories, everybody. I'm Dr. Marissa Caudill, and today it's my pleasure to be interviewing my friend and colleague, psychiatrist, Dr. Jennifer Reid. Welcome, Jennifer.
Thank you for having me, Marissa.
Yeah, so we've recorded quite a few podcasts together now over the last few years. So we trained together at UCLA. Jennifer was an internal medicine resident. I remember that month we worked together very vividly because as a psychiatry resident, I did not have a lot of faith in my ability to handle these tertiary care, really sick patients at the UCLA inpatient ward. And you were, by that time, it was at least midway through the year, a pretty seasoned internal medicine resident. And you were just like, yeah, whatever, this is no big deal. But I was like having a lot of adrenaline pumping through my veins, I remember. And then you joined our psychiatry program the following, like within a few months. So we trained together. And then we were just discussing, like, what happened after that.
Yeah.
You want to fill our listeners in?
Sure. Yeah, oh my gosh. I remember that time very clearly because we had letter assigned to each team in medicine, as you remember, and ours was F. And so we would answer the phone F medicine, which like I still joke with my husband. Yes. We still laugh about that F medicine because that's really how I was feeling.
Actually, you know what though? Now that you say that, because you have you have a smile in your voice when you talk sometimes. And so when you just said F medicine, like I do remember being in the room where we would write our notes, whatever, like our homeroom for the team.
Mm-hmm.
And you would answer the phone in this very smiley, sing-songy voice, like F medicine. I think because you were getting some joy out of being a little bit, not passive aggressive, but just like you were feeling like F medicine at that point.
Yeah, definitely. That was like very aligned. I was in alignment. Oh man,
I haven't thought about that in a long time.
Yeah, so let's see. Switching over, I mean, it was really fortunate to get a spot and switch over as a second year and then kind of didn't look back from there. I loved the group of residents that we got to work with. I mean, we had such a terrific class. And then finished and was married by that time. My husband still had more training. So we stayed in LA and I did sort of he calls it my part-time fellowship, which sort of it was. It was this, complex mood disorders, clinical part-time, and then also some research. And then I worked for LA County for about a year and a half, 2 years, I guess, with like a locum tenens company, which was unusual for the county to do that. And I still get recruitments from locums. So that was the downside of that 2-year stint is that they still are asking me if I have any openings.
I think we all
in California.
Get those. I think every psychiatrist gets those. Yeah, if you're on the list ever, they're never going to take you off. Yeah,
never going to take me off. So then let's see. We moved out. He had a fellowship in New York, and so while I was there, I had a brand new baby and then a little bit older one, and ended up getting a nanny for the year and sort of joining like a private practice that was run by one main psychiatrist. They would sort of screen patients for us and then kind of assign them to us. And then they would take a portion of the insurance reimbursements that we received. And I learned a lot that year, not so much clinically, but more financially and just the business side of things. And honestly, how terrible that setup is for psychiatrists in particular. But I don't know about other fields, but you're already getting a portion of these insurance reimbursements, which are already low for mental health, obviously, still today, even though parity laws exist. And so then you're getting a portion of that. And so when I talk to residents now about private practice, I always talk about like this model exists and you will be asked probably to join one, but make sure that it's not someone who's taking, 40% of earnings or something, some crazy amount. Make sure that there is enough coming from that group because you can do this on your own without it. And I think that's what your company really speaks to is that we can with the right structure and support. So did that year in New York and then moved to the Philadelphia area and took a job in an academic, hospital, was in the outpatient psychiatry clinic there. And because I like to do a lot of different things at once, I ended up doing some oncology work, like in a cancer center. I was consulting in the family medicine department with the residents, teaching them about psychiatry and doing lectures. And then eventually I was running the outpatient clinic as medical director, which we can certainly talk about. But as far as like being in alignment, it was very much the opposite. Like I'm the youngest of three. I'm used to sort of skirting the rules and choosing which ones I want to adhere to and sort of being a medical director, you very much have to be towing the line and sort of like passing along the party message. And I found myself like agitating for my colleagues a lot, and that did not go over entirely well in that setting. So, I was there for a couple of years, but really was very relieved to step aside out of that role, and then decided to go into private practice and just have more flexibility. My kids were a little older, and I was tired of the commute. I was tired of the inflexibility of that setting. I had learned a ton. It felt kind of like another fellowship or residency because I was around all these brilliant people, right? And learned and would like sneak into lectures when I could or run cases by someone, just learned, like soaked it all up. And then I was like, I think I'm ready for private practice, and left in 2019 and I was still commuting into Philadelphia. I live out in the suburbs. And then, COVID hit and all of that changed. Instead of 4 days a week commuting, I was all days a week in my home office with kids in school, I should say, loosely. And so it was interesting, right? I almost think about my private practice in two sections there, because the 2019 to COVID was very different. I was commuting in, I was seeing people in person. It was a lot of referrals from the academic center because people knew I had opened a private practice. We're not allowed to like recruit, but they sent people my way. And then after COVID, it's, all telehealth, adjusting to, at least there were some waived medication limits there that are now unwaived again, unfortunately, but that there was a little bit more flexibility to prescribe via telehealth. So that was up until actually about a year and a half ago, when I stopped seeing patients temporarily because I was working on a book, and I was kind of burned out. And I was like, the private practice model, I was doing what it was supposed to look like, and it just wasn't working for me, and it wasn't the right fit. And I was like, I've got to figure this out. And so I did step away and shifted attention there and kind of used that book advance and, other savings to sort of step away from clinical care for a bit. And then only recently have gone back to it in my own way.
Okay, I want to unpack a lot of that.
Yeah.
That was
Sorry, that was
a decade
long-winded.
of No, it wasn't. It wasn't. It was perfect. But it's just like a decade of your life and a lot that actually happened in there that I think our listeners, I assume, the few that there are like interested in how does this happen? Like, how do I go from being the academic doctor to doing something else, or the employed doctor to doing something else? So it sounds like you knew, because your husband was finishing training and going to be doing another fellowship, that you were kind of in a waiting period right after we graduated in LA. So you took like a locum tenens job. That's a nice, easy out, right? Like they never expected you to be permanent. So that seems like it was probably not emotionally draining to just be like, okay, my time's up. I'm moving across the country.
Correct.
That makes sense to me. Then did you always, because then you said you went to basically a private practice group that was insurance based. I think, again, that's another pretty common, although not, I mean, certainly the minority of physicians are practicing in that way, because we know that reimbursement rates from insurance providers to small groups is not as good as the big groups that can negotiate, like at universities. So you experienced that directly, and now you've told the tale of caution to people that, like, if you're going to go and accept these lower insurance reimbursements, make sure that you're not always giving up 40% for everything you bill. There should be like, the cap is this much to pay for my share of the rent and the staff that is shared, et cetera. And then beyond that, I get to keep it. That should be negotiated in the contracts. And then you went to academics. Why? Why did you leave that to go to academic medicine? At the point that you made that decision, was it your story that you felt like you would do better in academic medicine, or you wanted to be in academic medicine?
Well, part of it was, living in Manhattan with two little babies was really hard. You had to try and get a stroller onto the subway. I couldn't get the stroller down the Gristedes aisle grocery store. So very pragmatically, I think we didn't want to stay in Manhattan. And so we were looking for other jobs, and we were considering coming back out to California, going to Orange County, I think, at the Kaiser system. My husband had looked at that, and I had sort of looked at options. And then his family is out east with us, so that was one of the deciding factors. And I think the academic piece for me, I did want to be in that kind of educational atmosphere. I think being out for a bit, doing sort of county work, doing this sort of private practice model, I really missed the collaborative, academic focus. I miss being a desk away from someone who was doing really interesting research or was an expert in some specific field. I mean, UCLA was just full of those kinds of individuals. And so was missing that. And so I think I just put my CV together, a cover sheet, and literally just like sent it right to the chair at this academic department. And I was like, hi, I'm moving to the area. Do you want to interview me? And fortunately, it ended up working out. I think they had some attrition of people right before I arrived because there were some challenges in that work atmosphere. So that was to my benefit, though eventually I was, experiencing that myself. So, but for me, yeah, I did want that setting. I didn't get, when it comes to salary, and again talking with residents about that, the salary in an academic center was not what I could have made, even in private practice or in another site. But I really wanted the kind of additional academic support. I think there's a part of me that just didn't feel ready to be on my own in private practice and wanted that collegiality, but also more learning. I was like, I kind of want to get more experience with really smart people doing this before I hang up my shingle and start.
I think that's a really common feeling that we tend to have as physicians. I think as physicians, we are usually, even though you're the third born and the one who shakes against the rules, like that's kind of not the standard physician. The physician is usually the firstborn rule follower because it is such a clear-cut path. Like you have to do all of these things in a row in order and do well in them in order to even get into medical school and get into residency programs. So if there's a big resistance in your personality, that's usually hard to do, hard to complete to the point that you do. But I think part of that too is this feeling of we need that scaffolding to feel secure. Because if you think about it, most of us make it to almost 30 before we've had to go out on our own and prove ourselves with our own work, right? And just because of our experience and what we've done. Whereas regular people who aren't crazy like us, obtaining all these degrees and staying in school until they're like 30 years old, like they get more experience at a younger age of trusting that like, I know I can do this because I've done it before. So yeah, I think it is very common. Even people who've been in practice for like decades, if they want to go and practice a new field that's adjacent to their field, even if they have a lot of experience, I hear a lot of physicians saying like, well, first I'll have to get the training or the board certification before I can do that thing. And it's like, well, you may have been doing hormones for women for 10 years. Why do you need the fellowship or the board certification? Like you already know this. You could probably teach it, right? But we have this idea in our heads that we need to do more. It's that insecurity that maybe was contributing. And I can definitely relate to that. I think many listeners can. All right. So you settled for less pay because, again, it's familiar too. It's a little bit of Stockholm syndrome. It's like it's familiar to be in the academic setting with all of its, good sides and dysfunctions. We've all lived through it by that point in time. So then you are more likely to put up with it again, right? So when you left, was it a mutual decision? Was it your heart telling you had to leave? Was there a point where you're like, no more of this, I can't do it? Or was it a more gradual, yeah, I think I'm going to do my own thing?
Yeah. I mean, I think that, a big piece of it was being in this administrative role. And I distinctly remember coming in for a meeting with, the leadership and saying, my colleague is not on the faculty. She was a clinician, but off of the faculty system. And I was trying to advocate for her to get some administrative time. I was always advocating for administrative time so our docs could actually get notes done and not do it at home with their kids clamoring on them. But, and that led to a meeting where it was essentially like, we aren't going to keep you in this position anymore. We're bringing in this sort of man stepping in to do this role. And you're out kind of in a single meeting. So it was sort of like this abrupt and like obviously uncomfortable. I had to go tell people like this is changing. And I certainly had a lot of support from them because I think things had stabilized while I was running it. But that was the way the cookie crumbled, so to speak. And I think I was so mixed. I remember coming back to my office and actually feeling really relieved and almost excited that, okay, I have this out of the way. Now I can move on in other interesting things here in this center. I was doing that by then some clinical research with, a doctor who's just really well known in the field. And that was really exciting. And I was like, I'll just stick it out. But I think the way that went down and the discomfort I felt and the treatment there, it just didn't feel like I was just sort of like, this is not a receptive, supportive place. Even if I can grab all these things that I'm interested in, that dynamic just really soured me that, these were women who were making these choices. So that was just really hard because I was like, oh, okay. So I see how this is going to go. Things are very political, right? So then I just finally said, I don't feel good about myself staying here. I don't respect the choices I'm making staying here because I feel like I'm seen as the one who just got like pulled out, like the hook pulled off the stage. So ended up leaving, and it was a mixed bag. I mean, I really missed the people that I worked with. I had made some great friends. There were really awesome people there that I was trying to support. I was sort of leaving them hanging because someone else was stepping in who maybe wasn't as focused on their needs and balance, homework and home life balance as well. So that was hard, but I also felt relief, and I felt immediately the sort of excitement of the creative process of private practice. I was like, this is kind of fun, like creating a website. And I made and ordered so many business cards. Like I still have piles of them because I really over ordered, But just the idea of like I'm building something myself, it felt instantly so good. And I was like, oh, okay. So this is something that I needed to take that leap to find it. But once I was there, I was like, this is much more me, you know?
Yeah. Yeah. And I think life has phases, right? It's not to bash the experience that we all have in training or for those people who stay in academia. My husband stayed in academia after training for like 8 years. I don't know how he
Mm.
did it, but he did. And he still continues to work in basically an academic environment, even though it's not officially affiliated with the university right now. It's a very similar collaborative environment. And there's people who
Mm.
really like that and thrive in it. And it's good and important that we need to have doctors
Yeah.
who do that. But I'm with you. I think there's some of us who, my analogy, what I said is for years when I was working at Kaiser, I kept trying to make that shirt fit, like changing my
Mm.
schedule, doing more kids, doing more adults, taking on a more admin role, taking on leadership role. And ultimately it was like, this just isn't me. Like it doesn't work for me.
Yeah.
And so I left and I had the same feelings you had, which was a lot of guilt because in those systems, everybody's so kind of overworked too, or there's so much work and it's not evenly divided. And so the people who are
Mhm.
willing to work, you're leaving as one of those people is going to
Yeah.
burden them more. So there's a lot of feeling guilty because my
Yeah.
colleague in the child psychiatry department at Kaiser was like, no, you can't leave. And I felt like such a jerk because I was like, I know, this is like the worst
Yeah.
because already we were
Yes.
drowning. I mean, people had like a 3-month wait list to see the doctor and it was only going to get worse. Um, but we ultimately have to be responsible for our own happiness. And I'm with you. I think choosing to do your own thing gives you so much more energy because you're free to really do
Yeah.
whatever you want to do. Um, so tell me about now, after those years in private practice, how did you decide to become an author and what was that process like?
Yeah. I mean, I think that I started seeing patients just, whoever referred to me and saw whoever it was and took care of them and didn't really even think about like, what's my niche? What am I most interested in? And in fact, had a lot of guilt about trying to create a practice that really did align with what I wanted to treat. Because again, I wasn't seeing everyone and I had been trained to see everyone. We all have in our academic settings. And so it's like, why would I suddenly only see a portion of people? Or why am I doing a self-pay practice, which was really created a lot of guilt. How do I price it? What do I charge? It was just like, oh my gosh. And I think part of my coping with that guilt, ironically, is that's the book, was in trying to create information that was accessible outside of my office because it was this, especially with COVID, this referral overload. And there were so many people I couldn't fit. And I didn't have anything to offer them except like, here's a list of names that I didn't know if they were also full probably. And so I think my managing my guilt in this situation, one of the more positive ways, there were others, was to say, how can I share this information in the world? And part of that was creating a podcast. Part of that was for me because I was like, I want to talk to people that are still doing really good things and are making positive changes and are engaged and smart. And that was great. But also it was like, how do I get this info out? And I think that was me starting to like write a blog and trying to share some of these ideas and kept coming back to guilt because I was having it as a working mom. My kids kept knocking on the door and I'd be like, no, I have to see more patients. But then they weren't getting their schoolwork. I mean, every mom went through it during that time. And I was just like, I need this creative outlet. And when I looked back in my career and even in my in medical school, I always had some sort of outlet, some sort of creative. Like in medical school, we did musicals. I was in Guys and Dolls, and we did a Shakespeare play, and and I've always kind of sung in bands and just found some way for a creative outlet. And I think this writing took me by surprise as one of those cathartic outlets because I never saw myself as a writer. Like I was afraid of writing courses in college, and so many of our classmates in psychiatry were writers and, just like artists and actors and philosophers. And I think I was just like, I'm the science one. So it was a surprise to explore that. But I did find that writing helped me organize my thoughts, helped me clarify my thoughts. And that was really exciting. And then it just kind of grew from there. And then it started to become this challenge I had. Like, how could this actually become something? Could I get someone to support me in this, to represent me? Could I sell this book? Then it became this challenge because I was like, if I actually published the book, think how many people would actually, getting a book to sell is the next journey, but at least if it's available, it's sitting behind me, that's an option for people. So it's been kind of a wild ride. I think the expectations I placed on it were mixed. In some cases, they were very grandiose. And in others, I was like, I'm just proud it's done and there, available. So I'm still processing that. You still have all these dreams of what you want it to be or what you want it to do. And so I think I'm trying to figure out where to put my time and energy to actually move it forward, but not feel like I'm just constantly churning or selling, or it just, because that does not feel good,
So when you had the idea to write this book about guilt and managing guilt, did you start by writing some chapters just on your laptop, or did you wait? Did you pitch it first? What was that process like?
Yeah. Well, I had written kind of a blog entry where I come up with this idea of a guilt equation. I was just like, how do I simplify this? And I think I kept kind of chewing on that and coming up with different ideas around that. And then just basically started working on a proposal. I Googled, how do you sell a nonfiction book, And it was first you have to do a proposal. So then I found Jane Friedman has this great site for authors. It's here's an example of a proposal. And I downloaded that and just started filling in the spots, comparable books and biography and who would sort of support me if I needed blurbs and things like that, and some example chapters. Just started to kind of build it out and sent it out to a bunch of independent publishers and a bunch of agents, and got a little bit of interest from a few agents. One of them wanted me to print out 80 pages and mail it to her in New York. It was very old school. Most of them were more modern than that. I know. She was like, I need it in an envelope. I was like, okay. But then eventually did get a small offer from an independent publisher, and then used that. A friend of mine is an author and encouraged me to use that to try and connect with an agent. And so had an agent, and then she repitched it to, the bigger publishers to get a deal. And then that happened. And then I kind of had to finish writing it, right? You sell it on proposal, and then you have to finish the book, which was kind of a slow process. I think I was in the medicine mindset. So I was like, I've got to get this done. I've got to get it done fast. And, blah, blah, blah. And I turn it in. And then my editor was like, okay, great. And I wouldn't hear from her for a long time. And I'd be like, oh. And then finally it would come back and she would have provided very helpful edits. But it just, the pace of it was different than medicine.
I think the pace of everything is different than medicine.
Absolutely.
My son and I were watching, this new version of ER called The Pit. Have you seen it with Noah Kaufman?
Mm-hmm.
So we watched it together, and he kept looking at me and he's like, is this what you did? Is this what it's like? Because he is very much a creative person. He loves downtime. If we have a busy weekend and he doesn't get a day to just chill, he's he will let us know oh, I feel like I didn't get to relax at all this weekend. I'm so tired. So for him, I think even just watching people running around in ER was exhausting his nervous system. I was like, yeah, I didn't do ER. That's why I didn't do ER, because that's a little much for me too. But we all have to train in an ER, no matter your medical specialty. You spend time in an ER, and it's pretty much like that. This is a trauma ER, but still, you just don't know what's going to come through the doors. So yeah, I think we forget sometimes that the world we were trained to practice in is unique. And a lot of the rest of the world doesn't have those same, I need it now kind of deadlines. So that's interesting.
Yeah.
So how long was the process like from you? How long did it take you from getting told, yeah, we're going to pay you for this book, here's your advance, to write the first draft? And then how many iterations were there? And what was the whole process, start to finish, timeline-wise?
So I think I officially got that final offer October of 23, and then wrote the book, probably turned it in the following year in like November or December. And then I think we went through 2 or 3 like major edits. And then we did more of like the copyright edit. And my editor was terrific. She really helped me kind of bring these ideas into a very clear focus. I mean, I didn't want it to be super like, here are the top 3 reasons, some of the different, but that's what people want, is they want these in specifics, and it makes sense. And that's what I'm talking about in interviews. But I was like, I don't want to overly condense this or simplify it where it just loses all benefit. And so she did help me kind of organize it and write it for a lay reader, because we're used to writing either our notes or writing journal articles, things like that. So that was really helpful. And then finally, I think we submitted it. I think you have to submit it at least, is it either 6 or 9 months? I'm already forgetting. You submit the final manuscript, and then it's that many months later. I think it's 9 that it's out, on the shelves. Yeah.
Wow. So it's a long process.
It's a long process. So October 23, and it's published January 26.
Yeah. It's quite a long time.
So it's quite a long time.
It's a long pregnancy.
It is. And that's what it felt like. It's just like, I have this thing coming, and they're like, sure you do. And I'm like, no, I really. And like, they're like, I can't say anything. And I'm like, I know, it's coming. And just got like tired of talking about it by the time it arrived. And then I was like,
yeah, I bet that's true. I bet by the time it arrives, you're just like, oh, I'm so sick of this. Even though it's like your passion project, but you're like, it was my passion project in October 2023, but now I'm on to new things. Yeah, it's interesting. I didn't know that whole lengthy process. So let's tell everyone, it's right behind you. The book title is Guilt-Free, and the subtitle is
Reclaiming Your Life from Unreasonable Expectations.
Right. And you are an excellent writer. I really enjoyed the book.
Thank
I
you.
loved the guilt equation. I think I shared with you another book I had read had a similar equation, but I find that kind of, I don't know, mental notation so easy for me to get my head around and to grasp, and it just makes sense. So it appealed to my brain. I don't know what that says about you and me, but
no, mine too. Yeah, absolutely. I was like, well, those are the best teachers, right? They take these really complex subjects and they illuminate it in a really simple way. So that was certainly the goal. So I'm glad it was helpful for you. Yeah.
Right. So that leads to a segue in a conversation. And everyone, the show notes will have a link to buy Jennifer's book, and it's really good. You should definitely take a read. But we were talking before this about another simple concept that I got introduced to at a retreat this past weekend, which was setting annual goals. And this was a retreat for physicians, and having them be 3 levels of goals, with the bottom of a pyramid being A goals. These are things you've done before that you could do in a new way or at a greater level that will help you grow but won't transform you. Whereas B goals are doing something new that you yourself have never done, but you know that it's definitely possible because someone you know has done it. So even though you may not have the blueprint exactly of how you're going to get it done, you know people you can reach out to, you know there's a way. So that's kind of for you. You took these A goals of maybe I'll try private group practice, maybe I'll try academia. Those were all kind of A goals, like trying different versions of the same thing. But now becoming an author, that was definitely a B goal for you, right? And then C goals are the goals that are almost embarrassing to say out loud to yourself or your friends or family because no one you know has ever done them. You don't know how to do them. There doesn't really seem to be a path to get them done. They seem audacious for that reason. But it's important to have all these levels of goals if we really want to be growing and transforming and pushing ourselves to become, the best version of ourselves that we can be, to really be challenging ourselves to take on new things and have a greater impact in this life that we have. So for you, now you've become a published author. Like, what's next? What's the next B goal for you?
Well, I think that, certainly I would like to write another book. And I think sales, it's a little opaque about how many sales you actually need to have. And I think it just really depends on how good your next idea is. And so I'm sort of noodling on some ideas around being a woman at midlife and kind of what the next step is like for us, and trying to create something that talks about that developmental stage without making it all about perimenopause. Yes, that's an important aspect, but I think that becomes our kind of midlife transition discussion, and I think it's too narrow. I'm glad we're talking about it, but I'd like it to be broadened. So I think selling another book would be awesome. I guess that's an A goal now. Is that kind of what we're thinking? Okay. My B goal probably, and this is hard, right? To figure out what you want to do that maybe someone else has kind of done, but you don't have a clear path forward, which we very much like to have. A certificate we can get at least, right? But
Because once I have that credential with the little logo I can put on my website, I will guarantee my success.
That's all I need. That's all I need. Yeah. So I've basically tried to design a private practice for me that actually makes sense. So I've tried, like, could it be coaching? Could it be the way everyone does private practice most of the time in psychiatry, which is patients come in and you just follow them. And that's, it's good for secure income, and you also can manage them in long-term relationships. But for me, I wanted a little bit more of that pragmatic sort of specialty approach that you have in a lot of other fields. My husband's in orthopedics, my sister does breast surgery. So my sister joked that I'm trying to create surgical psychiatry. And to some degree, I am, because my brain likes both of those ideas. But the idea that I'm creating a practice that's really built around a 12-week program, like a 12-week where I incorporate interpersonal therapy, which I really like. We trained in at UCLA, where I incorporate CBT for insomnia without a certificate. I've just learned a ton because they do a ton of it.
How
and
dare
developed
you?
it at Penn. I know. I'm like, I still have some imposter syndrome there, and then bringing in my own, like, the framework of how I help people manage guilt. And that also feels a little bit audacious to be like, and I'm incorporating my ideas into my treatment protocol. But at the same time, they're built on all of the things that are evidence-based, right? I'm not just like, let me just make something up, like so many people, influencers in our field. So I think my next goal is, in building that and growing that for me, I'm also creating a new type of practice for the residents I work with, who a lot of, especially women that I've talked with that are in training, want something like this. They see, like, okay, private practice I get, but I don't know that I want to follow someone for the next 20 years. Like, that just feels I get full, that practice is full, and then I kind of just maintain it. And that doesn't feel as engaging as I want it to. I really like different challenges than that. So I think the audacity of it is just that I would be creating a model that, like, a subspecialty type model for psychiatry in the outpatient setting, to see the people that don't need long-term care or don't want long-term care, might be turning to coaching because that's a little bit more, they can wrap their head around it. But with my model, they could submit to insurance, right? Because it is under the psychiatry kind of rubric. So I think that's probably my B goal right now, is how to do that myself. But then, do one, learn one, see one. What is it? See one, do one, teach one. Yes, that's what I'm trying to do, right? I'm creating it to do one so that I can teach one, because I think there are, mental health is changing. AI is rapidly growing. Any of the online platforms are growing. Like, I do think we have to adjust.
Yeah, definitely.
Right? To not be obsolete.
I'm biting my tongue to not interrupt you because I'm, like, excited.
No,
by what
please
you're
jump
saying.
in.
Well, so I
wanna
think,
hear.
as you know, we learned from a lot of analytic supervisors in our training. And in the 50s and 60s, that was kind of the way. It was just kind of like, I don't know. To me, it always felt a little misaligned, like that you want this person to shape their life around your vacation availability, see you multiple times a week, and stay with you for years. That doesn't really seem like you actually want them to get better. And then I think CBT was born out of that, like, can't we do this better and faster? But it's still not time limited. It's not 12 weeks. It's like, well, this is the approach we're going to take, and it'll take as long as it takes, kind of depending on how good you are at it and how hard you work. I think we're definitely leaning and growing and evolving into, like, just tell me what to do and I'll do it kind of model. And I think you're right. Like, to have a time limited, like, these are the steps. Maybe you have to do it more than one time. But, like, if you get the principles of these paths of how you can live with less guilt and less anxiety, I think that's beautiful. And sleeping well is a big part of that, as we both know. Like, it's a foundational aspect of your brain health and your mental health. So I think
Mhm.
that's great. And I think you're right. It has the potential to have a much greater impact because you can make it an evidence-based treatment. You can make it something that could be deliverable via an app or that people could kind of self-serve rather than needing to come to the office of this provider. And so, yeah, I love that. I think it's a beautiful vision. I like your
Yeah,
big
and I
goal.
thank you, thank you. I mean, I do think like, I just recently, had a colleague in a different field in medicine who was having a ton of trouble sleeping and had never heard of CBT for insomnia, like, didn't even have that concept. It was either, like, don't sleep or, like, take ZzzQuil or a benzo or Ambien. That was it. And I was like, "Have you heard of this thing?" And they were like, "This what?" And I was kind of, like, sort of blown away, but I do think it's not known, but I sent him this workbook that I'm gonna be giving patients because that's you work with me for a few sessions, and then you take this workbook and keep using it. You don't need me to go over the skills with you 100 times because you have the capacity to go out and really make that change, and people can't afford it. They can't afford the time or the cost of forever care. Not everyone. Some people can, or some people have insurance coverage, but I just think, like, it's a missing space, and I keep thinking, like, I'm gonna find it, like, I'm gonna go out and someone's doing this already, and I'm gonna just learn it from them because that would be way easier, but I'm not finding it. I'm just not seeing
No, I
what
think
I'm
we're definitely
describing.
at the cusp of all of this. I think for the most part, clinicians are still holding on to the old model, which is like, no, I don't want to give away the secrets and let them do it themselves because they need to know how to come to me to get it right. For some things, I think that is true. Some things are pretty nuanced. I'm working with a family now who has a child with OCD symptoms. And so helping them
Mm,
understand like how you do that kind of exposure response prevention
yeah,
CBT with your child, that's pretty nuanced actually,
yeah,
because it's not just like follow this because you can do it wrong. But CBT for insomnia, it's a little bit more cut and dry. It's very much like if you do these things repeatedly, like your body habituates to sleep. And if you stop doing these things, you're going to have less anxiety about when you can't sleep. And so, like, I
yeah.
agree. There are definitely times and places, and especially an example for like an educated MD patient, like they should be able to take the workbook and run with it, right? And understand those
Mhm.
things. And I think to hold on, and this is where I think AI is really leading to this democratization of knowledge. I mean, I've had so many conversations with my kids, as I'm sure you have, about like, I just don't know what this is going to mean, but I know that it's
Yeah.
inevitable that the kinds of things you're talking about, right? Like CBT for insomnia, there's such a lag. It's been the best evidenced treatment for insomnia for how many years now? Like,
Yeah.
I mean, since our training, so probably going on
Yeah.
20 years. And yet the general population and physicians don't know what it is. so so there's a big gap in like what we know and what's proven versus what's in practice in the world. And AI is going to make that happen just faster and faster because eventually people are going to, with AI, discover by searching that, like, oh, CBT for insomnia is the thing. Oh, there's this workbook online. Oh, I can buy it and do it myself. But to have an initial contact point or someone to go to when you have questions is definitely more valuable than just having a workbook to go with. Um, but I agree with you, like, it doesn't really make sense anymore when that data is out there and available, and it will only be increasingly out there and available to say, "Well, you have to pay $200, $500 an hour to see a psychiatrist to get this CBT for insomnia to really
Right.
understand it," because that's just not really true. I mean, there are some mental health conditions that are still always gonna require a physician's care, right? I'm not just
Yeah.
saying that everybody should be able to do this with AI as their guide, but there certainly are some conditions where it will be very useful. And I think
Mhm.
weight management, metabolic syndrome, insomnia, like, all these things are things that we know what works, but the general
Yeah.
population doesn't know what works, and there's a lot of false directions out there as, like, this is the solution, that's the solution. You can spend a lot of time and money trying to find the solution and feel like it's elusive, but
Mhm.
the answer is actually known.
Right, and I think also it was me getting comfortable with, this is what I really enjoy doing. I actually really enjoy doing CBT for insomnia, and I'll tell myself sometimes, like, "Why am I doing this?" Like, a psychiatrist doesn't usually do this, or we don't typically do IPT or this guilt work necessarily, but it's like I really enjoy doing this and I really see it help in a timely manner. And I don't want to be focused primarily on meds. That's not what I really enjoy doing. And there are people that do. I think that's a big piece. Is like I'm not suggesting this is for everyone, either provider or patient. But it's like, how do we create more options for those who are going into the field or considering the field, where they could see maybe they have a little bit more like me. Like I started in medicine for a reason because I did kind of want, like, I was like, how can I keep this really pragmatic and practical? And psychiatry felt a little elusive. And so it's like, how do I combine those two things in my own life where I come from a family of surgeons, but I'm really interested in how the mind works. So like, it makes sense. Like in hindsight, you look back and you're like, oh yeah, okay. But it's hard to kind
of like, yeah, that's why I got where I am. That makes sense. It tracks.
Yeah.
All right. Well, this has been a really great conversation. I love chatting with you always. Thank you so much. So do you have a website for Guilt Free or for any of your upcoming programming for people to get on? Do you have a newsletter? Like, what do you want to share with listeners?
Yeah. I mean, my website is just jenniferreidmd.com. And so on there, they can find my Substack, which is newsletters. They can find my podcast, A Mind of Her Own. And something I'm really excited about, I created this guilt-free groups where people can just download a host guide and have their own group, like get together with other women and talk through the book over like 6 weeks. It's just like step by step and some questions to ask, because I think that's what's going to really create change. Like you talk about my C goal, it's to kind of shift women's experience with guilt across the world, perhaps, like that does feel really grandiose, but at the same time, like it's possible. Word of mouth and sharing and supporting each other. So anyway, they can find that on my website as well.
I love
it's all
that.
free.
And I love your idea about the perimenopause, menopause phase of life too. I agree with you. Like the medical aspects of it are important, but I've had lots of conversations with my husband where I feel like everything in my life up until now was like to get me to this point. But now I'm here looking out at, I don't know, I'm 49. So I'm like, I could have my great-grandmother lived to be 104. I'm like, that's a lot of years from now. Like, that's a lot of freaking years. So I'm like, if I'm looking at like all this life I've lived again, like, what was I thinking? I should have been preparing for this phase, right? Like this phase could be my most productive, most awesome phase because I don't care anymore. Well, not that I don't care anymore. I care a lot, but I'm not as scared as I was. I don't care anymore about I don't feel as strongly that I need all those credentials to put my neck out there and say, I think this, and this is how I like to help people. So I'm really excited about this phase of my life. One of my coaches says the phases of womanhood are maid, when you're like young, trying to get a mate, motherhood, and then maven, and then crone. She added maven because it didn't exist before. I'm like, I'm in the maven phase. Like this is a good phase of life. It's a beautiful phase of life. But I do think it's one where our stereotypes of beauty and all the pressures that are on us to maintain that like maid-like glow is hard. It's hard to juggle that and balance that with the inner drive. You have to be your truest self and to really leave a mark in your life that is meaningful and purposeful. So I love the idea of like really diving into that and the psychology of that. And I think it will resonate with millions of people around the world because there's not a lot that really speaks to us at this phase of life.
Right. That speaks about that stage. And that comes from some really interesting psychodynamic work, the sort of maiden, mother, maven, crone. I'm kind of wanting to relabel the crone. I mean, because it used to be based on power and wisdom, but now I really want to do the matriarch phase because it's also an M. But I think there's power there because I think you see these matriarchs out there doing this work, right? You see like Jane Goodall just crushing it, and you see like Gloria Steinem was one of my heroes. Like you see them out there doing this stuff, and you're like, oh, there's a lot ahead. It is exciting.
There's totally a lot.
So I'm excited to write about it as well for my own exploration. Which same with guilt. It was like it really helped me with my guilt. So, how do we do a little me search along the way?
Awesome. Thank you, Jennifer.
Thank you. So good to see you.
You too.